Hi everyone, welcome to Pharma World once again. This is the third part of the tutorial. I believe that this series of tutorials will help you to understand this topic clearly and have a firm pharmacokinetic base. You can check the basics of pharmacokinetics in the first and the second part of this tutorials for a better understanding. Listeners, there are a lot to know in the world of pharmacokinetics. So in this session, we'll discuss about the distribution of drugs across the body post-administration. For that, you have to know about compartment models. There are mainly two compartment models. More than two is also there. This is one compartment model, two compartment model that we'll learn in this session. And what is compartment model? It is a collective term for all those areas of the body into which a drug distributes approximately at the same rate. The one compartment model considers the entire body and all the organs and the tissues to be in one giant bucket. For example, this is the giant bucket here. And then the drug enters the central compartment. This drug enters the central compartment from somewhere outside the body, whether you give orally or you can give IV in that case. And then drugs leave the central compartment. So the drugs move from the central compartment, that is, it is being excreted out. So this is analogous to the drugs leaving the body. So let's discuss more about this one compartment as well as two compartment models. So regarding this one compartment model, this is the simplest model, allows for instantaneous distribution of drug throughout the blood and probably to some tissues. So what we can see here is that the drug movement into tissue 1 or tissue 2, okay, is homogeneous. That is, the amount of drug moved from the central compartment to the tissue 1 and then the coming again and the drug coming back from tissue 1 to the central compartment is same. Okay, the tissue may be a whole organ. Everything here in assumption is an ideal environment. So although this drug moves to the different organs, the movement to and fro is homogeneous and hence can be considered as one system, and hence can be represented by this diagram. Means both tissue 1, tissue 2, and the central compartment is considered to be a one bucket. Okay, everything that comes, every drug that comes into the central compartment, which include tissue 1, tissue 2, and the central compartment itself, is a one compartment, and the drugs move out from the one compartment in the similar fashion. Next is about the two compartment models. Drugs is injected to absorb and spread instantly through the blood in the rapidly equilibrium tissues. That is tissue 1 and tissue 2. That is the first compartment. And there is a significant delay while drug enters the rest of the body. That is the tissue 3, second compartment. So this is the second compartment here. So what exactly that happens? So the drug enters the central compartment from somewhere outside the body. Okay. Drug just leaves the central compartment by one of the two parts. So if we see here, this is the you can say drugs leaves the body from the central compartment, and drugs leaves the body to the second compartment, that is the V2. So consider it is like this is the what happens to when a drug enters the central compartment. This is the first thing, and this is the second thing. Okay, the drug that in the peripheral compartment can return to the central compartment, and drug recirculation occurs between the central and the peripheral compartment. But once the drug leaves the body, it doesn't re-enter the body. The two compartment model considers the entire body and all the organs or tissues to be in two buckets. But all the drug must leave through the body through a single bucket. It doesn't mean that the V2 will move to the excreted out. I mean excretion. It is not like that. The V2 will go to the central compartment, the V1, and ultimately it will be excreted out. And if you still have a conflict, have troubles like understanding, just let me go through that again. So this is the tissue 1, tissue 2, and the one in the central compartment comprises the V1, okay. And after that, this tissue 3 is the second compartment because the moment a drug enters the central compartment, it will distribute it into tissue 1 and tissue 2 in a homogeneous fashion, okay, just like we have discussed in the previous slide. But for the tissue 3, which is considered as the second compartment, the movement to the tissue 3 is quite slow. In that case, the pharmacokinetic parameters of distribution in the tissue 3 is different from tissue 1 and tissue 2. That's why it is considered as the second compartment. For example, if the movement of drugs towards the certain type of tissues, for example, fat, as well as the bone is being quite low, out there in the from PK parameters will be same, and that's why we have to think that okay, we cannot consider the distribution of the drugs in the liver, or can say in, in certain organs like in pancreas as compared to the bone is completely different. The PK parameters are different, so we have to consider these two things as a different compartment. That is the ideal of dividing this into a one, two, or more than that compartment models. So let's have a recap on the plasma half-life of a drug. So it means the time duration in which the plasma concentration of the drug fall by 50% of the early value. So if you have taken a 4 milligram dose, it ultimately means if it comes from the blood as a 4 milligram, so ultimately with a with a half-life like if 2 hours, after 2 hours, the 4 milligram will transform into 2 milligram in the plasma. So T-half doesn't reflect the absorption kinetics of the drug, but reflects on its mode way elimination kinetics that we need to remember. So how half-life is being associated with distribution or in the case of elimination? So half-life elimination is graphically represented with elimination curve that track the amount of drug in the body over time. So this is the time frame as well as this is the concentration as you can see here. Uh, and the drug plasma on the dependent axis. So this is the axis, this is the y-axis. Half-life we have considered as a 1 hour. So at the it's like a 0 hour. If this is an IV, okay. When you give an IV dose, this is how the graphs looks like. So when you give an IV dose and the concentration is like one, okay, one I can say milligram per ml or something like that. So at the span of 1 hour, it will become 0.5. So see, it will become half. Then after that, two half life, which is 0.25, and by the five times five half, like after 5 hours, it becomes like 0.03125. That is quite insignificant in that thing. So what exactly does this mean? That 90% of a means, for example, assuming no addition of additional drug, okay, after initial dose, ignoring any drug interactions. That's what I was trying to mean. No drug interactions. It's a single dose. And assuming a physiologically healthy individual, certain quantitative constant apply to all the drugs assuming first order pharmacokinetics. And that is we have discussed in our previous thing. So what is the zero order and first order pharmacokinetics. So everything, if it is in ideal conditions, so 90% of the given drug will have undergone elimination after approximately 3.3 half-lives. Even a further 94 to 97% of the drug will have been eliminated after 4 to 5 half-lives. That's what we can see in the previous slide. Thus, it follows that after 4 to 5 half-lives, the plasma concentration of a given drug will be below a clinical relevant concentration and thus will be considered eliminated. So this is very important when we design replicate design in bioavailability studies. So means there is a gap between dosing in the same individuals. For example, if the group A have been dosed, group A, a number of subjects have been dosed with a drug A, then we have to wait for like some half-life, 5 half-lives, so that we again dose these guys in the next session. So this is being used in phase 1 clinical trials, you can say viability studies, the concept of 5 half-life, which in various inclusion and exclusion criteria that is being required to understand what is the half-life, and we try to estimate the amount of drug that is being in the body, so that this amount of drug that is being left in the body will not affect the outcome of the study in if we dose these people again. So we'll discuss this later in our sessions that why exactly the half-life of this 5 half-life is important. So in the opposite way, it takes 5 half-lives to reach the steady-state plasma concentration. What is the steady-state plasma concentration? It means the concentration will be fixed in a certain range if we take the same dose at the same time. We'll not discuss the steady-state plasma concentration in this session, but we'll discuss later in our next subsequent sessions. So try to figure confidently in this figure only. Don't go for this one. This one is we'll discuss it later. So you can see that this 1, 2, 3, 4, 5. So this after 5 half-life, if you take the mean concentration, it will be in a straight line. So ultimately, this is the steady state plasma concentration. The concentration is, it will not move up and down from this toxic range. It will not move to the toxic range or not below the subtherapeutic range. So this is why 5 half-life, concept of half-life is important, apart from the elimination half-life, which is important for the understanding the washout period between two like dosing of the subjects between the two time frame. So that is how the half-life is important. And giving an example of a different half-life of different various drugs, you can see that it is some is like 6 to 12 hours, some like in hours only, okay, and also some in case of like 15 to 142 days. So a variability of half-life is there. So it is very difficult. And to be honest with you, if from the pharma company point of view, means no pharma company would like to have some drugs which have so much variabilities in that case. But this drugs have been developed earlier, a lot earlier, it's more than 2 3 decades back. So that's why it is still there. But currently, I would not see any drugs in which such a type of variability is in related to half life. So another facts about a drug called the which is used in case of osteoporosis. It's a quite common drug that is being used in osteoporosis. The half-life is completely different. You can see the early distribution half-life is 0.3 hours, early illumination half-life 1.75 hours, and terminal illumination half-life is 167 hours. So with low plasma concentration observed up to 28 days post-dose. So it is quite much variable half-life in this case of zoledronic acid because it affects the bones and it not follows a single compartment model. That's the most important thing. The moment it goes to the different compartment models, the half-life seems to change. While that is more advanced, I will not go to means why exactly what is the concept of this half-life. And currently, I will take in an advanced session why what type of different types of half-lives are there. In that case, for example, I will take this example and try to make you understand what are these things and why, how it is being delivered in clinical practice. So there are some factors to consider to identify the compartment models. The most two important is that first is the polarity of the drugs. That is, non-polar drugs undergo passive diffusion easily and so can enter tissues more rapidly than the polar ones. The other major factor is blood flow into the various organs. Where the tissues have a rich blood supplies, drugs can be delivered more quickly, whereas significant delay is unavoidable where blood flow is first. For many drugs, blood flow seems to be the one of the most critical factors. That's why I gave you the example of like bones as well as the fats, in which the blood supply is quite minimum as compared to the highly perfused organs like liver or kidney or the brain in that case. So in that case, any drugs that being associated with these type of tissues like bones, you will not see a single compartment model. There will be more than one. Well, I can see the figure with the rate of blood flows in organs. So you have one highly perfused and another is polyperfused. So you can see the polyperfused like fat, muscle, and bone. So for most of the tissues on a highly perfused will approximate the first compartment and the last one perfused with the second compartment. So the blood flow is very much important. Uh, we have discussed in our earlier sessions where liver takes a primary role in metabolism of drugs. And this is referred as first pass metabolism, generally being seen when a drug is being given orally. But you have to remember that liver is not only the place where the first pass metabolism may occur. Okay, during absorption, drug molecules must pass through the epithelial cells of the gut, and these cells contain the same sort of drug metabolism enzymes that are found in the liver. Consequently, first pass metabolism can also occur in the lining of the gut, though it is very minimum, but you have to remember that. Now, next term is the extraction ratio. What that means, the effect of first pass hepatic elimination on the bioavailability is expressed as the extraction ratio. So when you hear the term extraction ratio, it means the hepatic elimination, that the first pass metabolism that is being done on a drug in the liver. Next is how to measure the extraction ratio. The most good way is to find the concentration in the portal vein of a drug, suppose it is 10 milligram per liter, and then after that the drug is metabolized. What will be the concentration? Following metabolism, that is in the system in circulation. So this is the C out. Suppose it is 6. So the extraction ratio will be 10 minus 6, that will be 4 divided by 10. So it will be like 40%. So 40% of the drug is being metabolized. So the other way to find the extraction ratio is to know the hepatic blood flow. That is, this is the Q represents the hepatic blood flow, and the clearance of the volume of blood effectively cleared of drug per unit time. So this is the clearance. So if you know the clearance as well as the hepatic blood flow, we can measure the extraction ratio. So how this is associated with bioavailability? The systemic bioavailability of a drug F can be predicted from the extent of absorption, that is from the gut, and as well as from the extraction ratio. So F is equal to small f multiplied by 1 minus extraction ratio. This is how the uh, systemic bioavailability is being calculated from this extraction ratio. So let's see another example here in case of morphine. So CL liver is the hepatic blood clearance and the Q is the hepatic blood flow, which is like 90 liters per hour in a 70 kg adult male. And the clearance of the morphine, for example, morphine we have taken, that is around 60. Morphine is generally completely absorbed from the gut, so F is equal to 1. So in that case, so this is the F and this is the 1. And the hepatic extraction ratio for morphine is E is equal to clearance in the liver divided by the blood flow in the hepatic blood flow. So ultimately it comes to be like 33%, and 1 minus here, that is 1 minus 0.33, it comes to 67. So the viability of a drug of this morphine is 67%. So if you have this data, we can able to calculate the viability of this type of drugs. So these pictures show some examples of drug with high intrinsic clearance. Here you can see that hepatic extraction ratio. So it is not was the one, and so these drugs, lidocaine, cocaine, you can say the hepatic extraction ratio is quite high in that case, and so the overall viability will be less in these drugs. So one more topic should know, that is the volume of distribution. So it reflects the tendency of a drug to distribute out of the blood into the tissues. Okay, moving of the means that is moving the drug from the blood into the tissues. So a large volume indicates a strong tendency to distribute in the tissue. This is how you remember the volume of distribution. Otherwise, it will become very complex. The moment you say we can see the apparent volume distribution, it's almost similar. So what is a well, BD? It is defined as the proportionally constant that relates the total amount of drug in the body to the plasma concentration of drug at a given time. So drug in the body means the whole body to the plasma concentration, and we are not taking the whole body but only the plasma concentration. That is, and you should remember the simplest thing that I try to remember is that the tendency of a drug to distribute it out of the blood in the tissues. The more the tendency, higher the volume distribution. So here we have two situations. In the first situation, is fairly simple. So this is the bottle. Now we have a volume V. So if you know the amount of drug dissolved in a known volume of a liquid, so concentration of the drug in that bottle will be like drug means it is the amount of drug dissolved. Suppose we have a 520 milligram on pressure, and the volume is like 100 ml. So the concentration is like 20 divided by 100. So that is quite simple. But in the second situation, if we know the amount of drug dissolved in an unknown volume of liquid, we don't know what exactly the bottle comprises of, how it is, whether 100 ml with 200 ml, we don't know what that. So in that case, what we will do? So we have to then to measure the concentration of the drug in the bottle. That is, we could determine with this by adding a known dose of the drug, stirring and removing a sample for analysis to determine the drug concentration. So that is need to be done in the lab, and that's how we can determine the concentration of the drug in the bottle. So let's try to understand in a more simplified way. Suppose in a patient, in they get known dose of a drug that is like D equal 100 milligram, and then we just take out the blood sample from the patient, then try to measure the concentration of the drug. So it came to be like 0.5 milligram per L. So with proper calculation, then we can calculate the volume of distribution to be 200 liter. So basically, it is a simple example with drug concentration 100 milligram and the volume of distribution obtained is 200 liter. So in that case, suppose if I give like 50 milligram of that dose, so will volume distribution will be 200 liter or it will be like 100 liter? That need to be answered. So in that case, concentration will be like D is equal to V. So we know that D is equal to 50 milligram and volume distribution that has been obtained is 200 liter. So if we take the blood sample from after getting 50 milligram of drug, so we'll get concentration is equal to 0.25. So this is the concentration of the drug in the plasma. So if we try to calculate the volume distribution here, so V is equal to D by C, D is like 50 milligram, and C is 0.25. So in that case, what you will get, it is the same volume distribution. So no matter what exactly you give, like 50 milligram, 100 milligram, 200 milligram, the volume of distribution for that particular drug will be same. It's a simple thing, but people get confused. So my students sometimes are not able to answer these questions regarding the volume distribution. So let's try to understand it more in a easier way. So drug with a high volume distribution has a propensity to leave the plasma and enter the extravascular components of the body, meaning that higher dose of the drug is required to a given a plasma concentration. So if a drug has a higher volume distribution, more distribution to other tissues. So if we compare only the arteries or the venous system, the surface area, or you can say the amount of blood that can be retained in that capillaries or the venous system, the arteries will be quite less. But if the drug moves to the tissues, so the total volume of our body will be quite high. So that is how we should try to visualize regarding the volume distribution. So the more the drug penetrates or moves to the extravascular tissue, the higher will be the volume distribution. So, side by side, conversely, a drug with a low volume distribution has a propensity to remain in the plasma, meaning a lower drug dose of a drug is required to achieve a given plasma concentration. So, this is the low volume distribution and the less distribution to other tissues. So, we have here three scenarios, A, B, and C. The first one is that the most of the drugs stay in the blood. You can see red color of the blood vessels means more amount of drugs is there in the blood vessels, and it is less in the tissues. So there will be blood concentration is high and then there is small volume distributions. The second scenario is like some of the drugs move from the blood channels to the tissues, and there is a the concentration of the drug in the plasma will be less. And however, the volume distribution is not so high, but it is higher as compared to the scenario A. The third one is the drug distributes strongly in the tissues. So most of the drugs moves into the tissues and stay there. So in that case, the concentration in the blood is quite low, and there will be a high volume of distribution. For example, chloroquine. So chloroquine is a very high volume of distribution. So the apparent volume distribution of certain drugs may vary significantly between patients depending on each patient individual physiology and pathophysiology. For example, in case of pediatric versus adult dosing, the body surface areas, lean mass, and other body composition varies and hence the volume distribution of both pediatric and adult people. Next is about the obesity and normal BMI. So the concentration affinity towards fat changes the volume distribution. Obese have more fat, so ultimately the volume distribution of certain drugs is more in case of in obese individuals as compared to BMI. Although the drug is same, drug is constant, but since it is a the person has more fat, the volume distribution changes for the drug drastically. And other things like condition affecting plasma protein. Some drugs have more plasma protein bind, some are less plasma protein bind. So you have like liver disease in which the protein component of in your blood is quite less. In that case, the drug will not bind to the plasma protein, and the excess free blood will be there, free drug will be there, and it may affect the amount of drug that remains in the plasma, and therefore the apparent volume distribution. So the important point is that the volume distribution is different in the situations, and utmost care to be taken in dosing in different patients. So we can see here a few examples of drug with low, medium, and high volume distributions. The first one is adalimumab, warfarin, gentamicin. Gentamicin is water soluble, cannot pass through the cell membranes, and we have adalimumab, warfarin is like more, the size is very big, monoclonal antibody adalimumab is, so it cannot penetrate through the cell membranes quite easily. And about chloroquine, it has like 15,000, it's very high volume distribution. And generally because it has the propensity to move or it has penetrate most of the tissues like brain, eyes, heart, kidneys, leukocyte, etc. And therefore has a very large volume of distribution. So next, try to understand what is the clinical significance of the volume distribution. The most important utility is to find a loading dose of a drug. So loading dose of a drug is used generally to reach the steady state concentration. So it is being calculated, it is very easy calculation. So loading dose is equal to concentration of the drug, desired plasma concentration, that is the steady state concentration, in multiplied by the volume distribution divided by the viability. So this is how this loading dose can be calculated. So example of a loading dose is like in a condition like anti-epileptic, which in epilepsy, when a person is undergoing seizures. So in that case, we have to give a lot of bolus doses in the patients. So in that case, we give like phenytoin is being given as a loading dose, means we give a high dose of phenytoin, and after that the dose is being maintained. Similarly, the aspirin is also being given as a loading dose during a suspected mitral infarction. So after administration of a loading dose, additional maintenance dose can be administered to maintain the desired plasma concentration of the drug. So unlike the loading dose, which is dependent on the drug volume distribution, the maintenance dose is dependent on the clearance. So in case of seizure, we just control the seizure by giving a bolus of doses and reset the steady state plasma concentration, following which we have to maintain the steady state plasma concentration. For that, we need the drug clearance rather than the volume distribution. So it has been calculated as like is equal to CP represent the desired plasma concentration of the drug, the same as like the loading dose, but it will be multiplied by the clearance rate of drug, not by the volume distribution. So as you can see here, the difference between loading dose and maintaining dose, one depends on the volume distribution, another depends on the clearance. So loading dose is used to reach the steady state plasma concentration, whereas in maintenance dose, as the word maintenance, it is maintain the steady state concentration. So another example of loading dose and maintenance dose is about drug amiodarone. This is an anti-arrhythmic drug, so you have to give the drug quickly to save the patient. So in that case, the loading dose here is like 200 milligram TDS for 1 week, then 200 milligram twice daily for 1 week, and the maintenance dose you can see is only 100 to 200 milligram daily. Similarly, warfarin is also being used as a loading dose followed by maintenance dose. However, the maintenance dose here is a little bit different here because it depends on the INR, because we have to try to calculate the INR of the patient, and then we have to maintain the dose. It can be at plus or minus of the dose. It depends on the INR of the patients. We have to manage the dose of this warfarin. So a little bit of different in case of warfarin, but in most of the other cases, it shows a similar pattern. These are my references. Please like and share and subscribe my channel if you like the presentation. So in the next session, we'll discuss on EMS and pharmacokinetics. Goodbye. Thanks.